All right, well, it's 8 o'clock, so we'll get started. Welcome everyone to Department of Medicine Grand Rounds. And for today's introduction, Dr. Aji Jamali, our Division Chief of Nephrology, will introduce our guest speaker. Aji?
Good morning, Lynn, and thank you. It is my distinct pleasure today to introduce Dr. Brad Astor. Dr. Astor received his biomedical engineering degree as a bachelor's degree from University of Iowa. He earned his master's degree in electrical engineering at the Johns Hopkins University, where he also earned his master's in public health degree and his PhD in epidemiology. The title of his epidemiology thesis degree was Vascular Access for Hemodialysis. Dr. Astor also did his postdoctoral training at the Johns Hopkins, where he joined the faculty at the rank of assistant professor, then associate professor, and we were extremely fortunate to recruit him in 2011 as associate professor in the Division of Nephrology, Department of Medicine. Brad is now professor with tenure and director of research in our division. And we have been fortunate to work with him in the two primary areas of research for Brad. One area is dialysis vascular access that he will be talking to us about. And the other area is biomarkers and predictors of disease progression and outcomes in patients with CKD before and after kidney transplantation. Dr. Astor has been funded throughout his career. Currently, he has an R01 entitled Dynamic Prediction of Renal Failure using longitudinal prognostic information among patients with chronic kidney disease and kidney transplant. He's also PI on the U01 from NIDDK entitled APOL1 Long-Term Kidney Transplantation Outcomes, and he is leading the Upper Midwest Project. Brad has received a long list of awards for his research. I have selected 3. One is the Harry and Jeanette Weinberg Endowment Cardiovascular Research Award from the American Heart Association. Another one is the Research Excellence Award from the Division of Nephrology. And the most recent one is the Rankin Research Award from the Department of Medicine. In those 2 areas of research, Brad has published a whopping 275 refereed articles since 2000. Based on my calculations, and I'm always embarrassed to talk about calculations in front of Brad, that comes down to 13 papers a year. That combines with a top quality with an H index of 61, the total number of cited items 21,896 times. His first paper was published in the American Journal of Kidney Diseases in year 2000 and addressed the relation between gender and vascular access complications in hemodialysis patients. His last paper is from this past month, also in the American Journal of Kidney Diseases, one of our top journals, entitled AV Access Type and Risk of Mortality, Hospitalization, and Sepsis among elderly hemodialysis patients. I think he will be talking to us a little bit about this. Dr. Astor has a national level of credibility. He is a standing member of the NIH NIDDK KNOT study section. He has been invited to give presentations nationally and internationally. And he is also heavily involved with the education activities and work at University of Wisconsin, where he has been the course director and co-director of Population Health Sciences for Graduate Research Center. One key area of Brad's contribution has been mentorship. I consider Brad as the ultimate mentor in our division because he has, in the past 11 years, mentored faculty members, including myself, fellows, graduate students, undergraduate students. People have gone to become leaders in the US and abroad, being ambassadors for UW. I'll finish at a personal level. Brad is one of the brightest, most rigorous, honest, reliable, credible, kind, and team-oriented colleagues I've had the pleasure and privilege to work with. Brad has been an incredible source of compassion, energy, leadership, and friendship for me. I'm a big fan. Dr. Astor, thank you for your time. And thank you for your presentation that we are excited to see on dialysis vascular access. The platform is yours, Brad.
Well, thank you for that wonderful introduction, Aji. And I would also like to thank you for the last 10 years of your leadership and friendship and leadership of the division. Had I known this was presumably the last time you'll introduce me, I may have chosen a transplant-related topic, but we will be talking about vascular access. So I do have a consulting agreement with VascAlert, which is a manufacturer of a vascular access monitoring device that is not related to the work presented here. There is a substantial geographic variation in the incidence of end-stage renal disease or end-stage kidney disease or kidney failure. I'll probably use those terms interchangeably. There's substantial geographic variation around the world, but as in many things, the US is one of the leaders. We have one of the highest incidence rates of ESRD in the world, with about 375 cases per million per year. This has increased dramatically since 1990. So 30 years, it's gone from about 200 per million up to 375 per million. And now there's roughly 131,000 new cases of kidney failure in the US every year. The causes that are hypothesized for that, certainly the increasing age of the population, the increasing prevalence of diabetes, a lot of that due to the epidemic of obesity, and potentially some due to increased survival of cardiovascular disease. Cardiovascular disease and kidney disease share a lot of risk factors. So people that actually survive their heart attacks and strokes still have the risk factors. They're still at risk of kidney disease. They live long enough to reach kidney disease. And these are adjusted incidence of ESRD, just simply adjusted for age, sex, and race. You can see that even simply adjusting for that, the incidence has actually peaked, hopefully, and leveled off or even declined a little bit since about 2000 or 2005. And while we still think these risk factors are increasing, we will take a little bit of credit and maybe the prevention of chronic kidney disease progression from milder forms of chronic kidney disease. We have hopefully precluded some, or at least delayed some of the progression to kidney failure. Despite that leveling off in the incidence, at least the adjusted incidence, the prevalence of ESRD has continued to rise. So this is even more dramatic, from about 180,000 people in the US treated for chronic kidney disease in 1990. It's well over 750,000 people as of 2018, which is about 2.4 per thousand. I checked yesterday, and that is just over the cumulative number of COVID-19 deaths since that pandemic has started. So that's in the US. So a few more people are currently have ESRD in the US that have died from COVID-19 in this country. So there's three general types of treatment modalities for people with kidney failure. So they need renal replacement therapy to survive. And among these incident patients, only about 11% actually have a preemptive transplant or receive a transplant before they need dialysis. And a lot of that is due to the shortage of organs, also due to not being fully prepared for the eventuality of kidney failure. A growing number, but still very few, actually start peritoneal dialysis. And the vast majority, about 86%, start their therapy, renal replacement therapy, on hemodialysis. And if you look at the prevalence over time, that actually is different than among prevalent patients and among incident patients because of differential survival and people that initially start with hemodialysis but are put on the transplant waiting list, eventually getting transplanted. So among prevalent patients, about 62%, or nearly 500,000, are receiving in-center hemodialysis. 29% have a functioning transplant, and less than 10% are on peritoneal dialysis, and very few, but a growing number, are actually on home hemodialysis. But we'll focus on the in-center hemodialysis, which represents the majority of all these patients. So those that are starting dialysis, initiating hemodialysis, or those that have been on hemodialysis for whatever length of time, they all require a functioning vascular access. And that's what we'll be discussing today. So there's generally 3 types of renal replacement therapy. Most of them are on hemodialysis, and that requires a functioning access. There are generally 3 choices or treatment options for patients that are on chronic hemodialysis. And those are a central venous catheter, an arteriovenous graft, or an arteriovenous fistula. So a catheter can either be acute or, I have it in quotes, permanent. And you'll see why that's in quotes later. It is then, has an external port, usually placed in the internal jugular vein, but can be placed elsewhere. An arteriovenous graft, or AVG, can be made of synthetic or biological material, and that can be placed in the forearm, the upper arm, or less commonly in the chest or the thigh. And the third type is the arteriovenous fistula, or AVF, and that is surgically created using autologous vessels. And that is commonly placed in the forearm, the elbow, or I think at this point, predominantly the upper arm. And each of these has its own advantages and disadvantages. And this table was put together to explore those. So the main advantage, the primary advantage, maybe the only one, of the central venous catheter is it can be used almost immediately after being placed. Arteriovenous graft requires roughly 2 or 3 weeks, though there's a lot of work right now on manufacturing grafts that can be cannulated much more quickly in a day or 2 after placement. But generally it takes a few weeks after the creation of that for those anastomoses to heal and for that graft to mature and the vessels around it to mature. An arteriovenous fistula generally takes somewhere 6 to 12 weeks to mature, but a number of these have a need for assisted maturation or another intervention to help the maturation of that fistula. So it can, if things go well, it can be 6 to 12 weeks. If things go poorly, it can be much longer than that. And in this table is called primary failure. And actually very few of central venous catheters cannot be used pretty quickly after being placed. Arteriovenous grafts, there's a few more that are not usable in this time frame. And studies vary on arteriovenous fistula, how many are never used. And they range from 20 to 50 to up to 60% in some studies. And a lot of that is due to the failure of that vessel to mature and expand and be able to handle the flow rates required for chronic dialysis. If it does mature, the flow rates for a graft and a fistula are high and can support efficient dialysis. Central venous catheter flow rates are generally less than that, so it either requires more time or less complete dialysis and removal of toxins. And the biggest difference, the biggest downfall of the catheters is the number and frequency of complications. They have much higher need for interventions. They have a very high risk of thrombosis. And probably what we worry about most is the risk of infection. And a lot of studies, again, vary with this, but generally around 200 per 100 patient years, or a patient with a catheter for a year can expect to have 2 infections, which is much, much higher than the 8 per 100 person years in an arteriovenous graft, and even fewer in a fistula. And what we worry about are catheter-related bloodstream infections, bacteremia, and sepsis. If a catheter is used for prolonged use, more than 3 months, sometimes more than 6 months, it's a very high risk of central venous stenosis, which is associated with severe swelling, edema, and loss of that access site. And then these are not expected to last more than a year, around 2 years for a graft, and 5 years or more. Some people have them for decades for a fistula. But based on this very high risk of complications and especially infections, in 1997, these were the first clinical practice guidelines for vascular access. And these were put out by the Kidney Disease Outcomes Quality Initiative, or KDOQI. And they said cuffed tunneled central venous catheters, these are the permanent ones, should be discouraged as permanent vascular access. And based on the difference of complications between a fistula and a graft, they had a relatively weak statement that if it's not possible to establish a fistula, an access may be established with an AV graft. And there's some other relevant things to consider when making these decisions and looking at comparative studies. And one of those is that not all incident patients are even eligible for a fistula or graft creation. If they don't have adequate vessel size, vessel anatomy, or vascular health, they aren't even eligible for those. So they really should not be in the comparative studies if there's not a true decision to be made. The maturation of a fistula, both the time and the probability that it actually successfully matures, varies a lot by patient characteristics. In fact, Charmaine Locke and others have developed this failure to mature risk score. And this was the risk equation from the Reduce Failure to Mature 1 study. And this simple score was derived from 422 patients who had a first fistula created after they had initiated dialysis. So not any of those that were preemptive creations, but after they initiated dialysis, they had their first fistula placed. And they came up with this scoring system to define the risk of non-maturation or failure to mature. And you got points towards this score for being older, greater than 65, for having peripheral vascular disease, for having coronary artery disease, and also got points taken off if you were not of Black, Asian, Aboriginal, or other non-European descent. Then they validated this score in a separate group of 445 patients at 5 large dialysis centers in the US. It worked very well. For the 88 patients that they considered low risk, based on the score, 24% failed to mature. For the bulk of them in the middle, moderate risk, 34%, those at high risk, 50%. And there were only 11 considered very high risk, but they had a 69% failure rate for these first fistula. And the type of access in use varies significantly over time among patients on chronic dialysis. The graft or fistula, either type of AV access, can be placed at any time. As I said, very few are created before starting dialysis, even though it's recommended that they do so. Even fewer are fully mature and ready for cannulation to allow dialysis by the time it's needed for that patient. So importantly, the type of access and use at initiation is very likely to change throughout the course of the dialysis. And this is some work dating back to 2001 in the CHOICE study that we did. That's Choices for Healthy Outcomes in Caring for ESRD, or CHOICE. And this study enrolled 767 incident hemodialysis patients. This analysis was done on a subset of about half of those. So at initiation, when they first started dialysis, only 14% were using a fistula, about 20% were using a graft, and 66% were using a catheter of some type. And even after 6 months, both the fistula and graft had about doubled, but still a third of patients had never used a permanent access 6 months later, even though the guidelines had strongly suggested they not use a catheter for permanent dialysis. We also looked at the impact of nephrology referral time. So early referral we defined as having been referred to a nephrologist at least 12 months prior to starting dialysis. And it was shown that AV access use at initiation, those that were referred early had almost a 9-fold higher odds of starting with a graft or a fistula than somebody that was referred in the last month. And that wasn't, I mean, the magnitude of that was surprising, but the association was not really. What was more surprising is that the access use, even 6 months later, they don't catch up. They've obviously been under the care of a nephrologist. They've been seen 3 times a week in the dialysis clinic, but those that were referred early still have a 3.5-fold higher odds of using an AV graft or fistula compared to a catheter. And we also found that people that were referred early were more likely to have a fistula as their first access rather than a graft. So later that year, KDOQI updated their clinical practice guidelines. And they specifically had a goal of increasing the proportion of patients with a fistula. And one of the ways to do that was early identification and referral of patients with progressive kidney disease to a nephrologist to allow construction of an access prior to needing dialysis, and also to reevaluate for a fistula after every time a catheter or graft or previous fistula fails, reevaluate to see if you can put another fistula in. And then in 2003, CMS, working with the ESRD networks around the country, came up with the Fistula First Breakthrough Initiative. And they had about a dozen change concepts for increasing fistula use in the US, including continuous quality improvement review, and reviewing every person every time something happens. They also included timely referral to a nephrologist for evaluation and early referral to a vascular surgeon for evaluation and placement. So when the Fistula First came out in 2003, about 33% of prevalent patients were using a fistula at that point in time. And that had already increased from 1998, where about 26% were. But they had goals, the Fistula First in 2003, set goals that they wanted to achieve by June of 2006. And that was to increase from 33% to 40% of prevalent patients using a fistula. And they also had the goal of 50% use in incident patients. Well, this goal was achieved 10 months early. So it was actually achieved in 2005. And then based on the use of fistula in Japan and some European countries, it was well over 60%. They set a new goal for 2009 where 66% of prevalent patients should be using a fistula. So this just shows the results of the Fistula First initiative. It was 33% when the initiative came out. They met their goal at 40. It continued to increase. Hasn't quite reached the 66%, but very close. But then when we looked at this a little more closely, this increase in fistulas came almost exclusively at the expense of AV grafts. And actually the use of catheters hardly changed at all. So we were switching from grafts to fistula and not impacting catheter use at all. In fact, catheter use remained about 80% of incident patients, remained well over 25% in incident patients for that whole time period. And actually there was an increase in the extended use of catheters, presumably waiting for these fistula to mature, and accounting for those that didn't mature and failed and they had to start over. There was an increase in prolonged catheter use. So in 2015, recognizing that, they changed their name from Fistula First to Fistula First, Catheter Last. And they had specific goals of increasing AV fistulation utilization in all appropriate hemodialysis patients, and specifically decreasing the use of long-term catheters. They call long-term greater than 90 days, one that below 10%. So they did say appropriate patients. So they're starting to see that this one-size-fits-all store will not work for all patients. So the need now is to define who are these appropriate patients and what is the best approach to decrease catheter use. So we've worked on this and we've focused on older patients for a number of reasons. There is a greater probability of fistula maturation failure. Being greater than 65 gives you, I believe, 2 points in the fail to mature risk score. So there's a lower likelihood of having any benefit from a fistula placement. Older patients have a lower life expectancy. So even if they do achieve a mature, usable fistula, there's lower potential long-term benefit from having that. And data from the CHOICE study that we've worked on and others have shown there may be less benefit from a fistula compared to a graft or catheter in older patients as compared to younger patients. More than half the patients that are initiating dialysis are over 65. And then importantly, there are data available. Medicare covers nearly everyone with kidney failure on dialysis. They are sort of automatically Medicare eligible, but it doesn't kick in for 90 days. And there's a lot of access changes that can happen before starting dialysis or in those first 90 days. So those that are Medicare eligible before that provide data that's not available for younger patients. So this is one of the studies that we've done looking at catheter dependence. And this was work done by my wonderful doctoral student. This is Bainey Liu, who just finished her PhD in epidemiology in the Department of Population Health Sciences, along with Micah Chan, Alex Yevslin at the University of Michigan. So we use data from the United States Renal Data System, which covers nearly all dialysis patients in the US. It is linked to Medicare claims. And we also use Crown Web data, which are monthly reports from sampled dialysis units across the country. And they report on the access type that's actually in use at the end of each month. So our study population was patients aged at least 65 years. And we did that to exclude pre-dialysis access placements. We wanted to look at just their first access, their first AV access, either a fistula or graft. We wanted to look at that placed within the first year after initiation of dialysis. So we used older patients, so we had 2 years of Medicare eligibility prior to that, so we could see if anyone had one before that and exclude those. And we looked at all these placements between May of 2012 and May of 2017. So our outcome here was catheter dependence after an AV access creation. So this includes any time you spend on a catheter. We just counted the days that someone was using a catheter, thinking that they are at risk of the associated infections and other complications. So this includes the time during which a fistula or graft is maturing. It includes the time after, say, their graft has failed and they have to go back on a catheter. It includes the time if they have another fistula placed after that, and that one needs to mature. So we just counted up all those days. And this is sort of equivalent to an intention to treat analysis. Once you have a type placed, we start counting and we don't stop until the follow-up is over. So we counted cumulative catheter days. We also looked at the proportion of follow-up or the rate of catheter dependence. So how much catheter free time compared to how much total time or how much catheter dependence time. And we use generalized estimating equations to look at the catheter dependence over time. Negative binomial regression to look at the rate of catheter dependence. And importantly, we have to account for the informative censoring. Mortality is very high in this population. And once a patient dies, they can no longer have, they're no longer dependent on a catheter. And that could differ substantially between those that started with a fistula or started with a graft. So we have to account for those. And we did that in a number of ways, including creating a hypothetical immortal cohort and looking at those data. And we adjusted for a number of things, including demographics, comorbidities. We had measures of functional status. We had a lot of laboratory values at the time of initiation, and also the interval between initiation and placement. They were all in the first year, but some of them were very early and some of them were later. And a lot of things can change over time when somebody is on dialysis. So this figure shows the access types in use for those that initially had a fistula placed and those that initially had a graft placed, starting at the time of placement. And in this orange, mauve, salmon color are the deaths. And you can see by 3 years, it's well over 50% of those that had a fistula placed have died. And it's even higher for those that had a catheter placed had died. And then for those that had a fistula placed, the blue is fistula. Some of those had transitioned already to a graft over time. Over here, these are the ones that initially had a graft placed. Some of those did transition to a fistula. And these are missing or unknown up here. But in purple is the catheter use. So a fistula, you can see the catheter use, it's very high to start, and it goes down relatively slowly over time. And then there are few catheters used later in time for those that initially had a fistula placed. For those that initially had a graft placed, because they mature more quickly, there's a quicker drop off in the number of patients using a catheter. But then once they do mature, there's actually more people using a catheter. So we had 81% that their first permanent access was a fistula, about 20%, 19%, their first access place was a graft. And generally those who received a fistula were healthier compared to those who received a graft. So these are the same data, just presented a little different. So in red is the catheter use over time from 1 to 36 months of those that had a graft placed. You can see there's a steep drop off where fewer and fewer people are using a catheter. and then it sort of levels off. And then for those with a fistula, there's a slower drop off, but once it does level out, there are fewer people using a graft. And that transition is roughly at 1 year. When we look at the rate of catheter dependence, meaning we modeled this so we can adjust for differences in the patient characteristics, that the odds ratio is 1 at about 15 months after initiation. So presuming you put a catheter and a graft in the same people, about 15 months is where you would start getting a benefit from the fistula. But you can see at about 15 months, it's 30-some% of the population has died and are no longer there to receive any benefit. So when we look at this in the first 6 months, those that started with a graft had on average 48 catheter dependent days. Those that started on a fistula had 105 catheter dependent days. And then if we look at that in a per person year, extending everybody to 1 year, it was 130 of the days in the first year that somebody that started with a graft would need a catheter, and 295 for those that started with a fistula. So there was a difference of about 165 days in the first year. So there's 165 catheter days more in this group compared to the other group. Following that out for the first complete year, there's about 80 days. Within the first 2 years, there's 40 more catheter days. And extending that to 3 years, there's still a higher cumulative use of catheters in those that initially had a fistula placed. And all these were placed within the first year. So it's about a month more, a little less than a month more of catheter dependence for those with a fistula. We concluded from this that it was well known that there's longer initial catheter dependence. It was not known that there's greater cumulative catheter dependence associated with having a fistula placed. So we found that the fistula may not be the preferred access type for many older patients. And we need to look at specific patient characteristics when making those decisions, including the probability of maturation and the life expectancy. So the probability of getting any benefit and the extent of that benefit if it is realized. So in 2019, KDOQI released updated clinical practice guidelines. And I was on the working group that developed these. And they included in this a realization of a lot of this. Prior guidelines initiatives have emphasized a Fistula First approach to vascular access choice due to the lower complications. However, more recent data have challenged those associations because of the high complication rates of fistula maturation failure. And we need to reevaluate this Fistula First approach. The European Society in 2018 had their clinical practice guidelines included similar things, saying patient-specific choices for access should be investigated. Do patients with limited life expectancy benefit from a graft more than a fistula? And there were also research recommendations in the 2019 KDOQI update to develop and test risk prediction models to assist patient-specific decision-making. And they also importantly recognize that it's unlikely that randomized trials will be performed. So we must rely on high-quality observational data to inform these algorithms. So we have tried to inform some of this. Again, this is work led by Bainey Liu. And here we looked at associations with mortality and hospitalization and sepsis. And we use a target trial emulation approach. So this is where we try to emulate a randomized control trial. They're probably not going to be done. This may be the best we can do, is try to emulate this. So we try to emulate a trial to compare the effect of fistula versus graft placement on risk of mortality and hospitalization. again, used data from USRDS linked to Medicare claims. And we use target trial emulation principles, which I'll describe, and high dimensional propensity scores to emulate the random assignment that an RCT would have, and instrumental variable analysis to account for unmeasured confounders that randomization would usually take care of, but we can't do that in an observational study. So a target trial emulation approach, you actually design the trial you want to do. And then it makes you think about every step and every place where potential bias could come in. So you design the trial you want to do, and then using observational analytical techniques, try to replicate that. So again, we had those initiated dialysis between 2013 and 14, no access created before that. So again, we used those that were 67 years old, and people that were going to have one this time in the first 6 months after initiation. Our intervention was either a fistula placed or a graft placed. We wanted to emulate a random assignment, and the outcomes again were mortality, all cause and cause specific hospitalization, and sepsis. And we used an intention to treat analysis. So the follow-up was from the day the access was created, which was the intervention that we are emulating as randomly assigned, to death, lost to follow-up, or 3 years of follow-up. And then we had a priori subgroup analyses by sex, race, presence of diabetes, congestive heart failure, and peripheral vascular disease. So this is the high dimensional propensity score. You've probably heard of propensity scores. It is the propensity to get one treatment or the other. So in our case, it's the propensity for receiving a fistula. And usually you just throw all the important variables in, run a model that is associated with fistula placement, and you're good to go. But this high dimensional propensity score has been shown to actually pick up more of the difference between these in patients between these two groups. So you start by identifying different dimensions, and we had 6 dimensions, both diagnoses and codes for outpatient, inpatient, and from the physician supplier claims. For each dimension, we have 300 items. So those are any of these procedures or codes that occurred most frequently. You assess how frequently they occur. Then you prioritize those by the degree of imbalance between the fistula and grafts, or how closely it's related to that decision. Then you combine these and include the top 500 covariates, as well as any that you want to make sure to include in your model. And then you estimate this exposure propensity. How likely is a specific patient to have a fistula rather than a graft? And then we also used instrumental variable analysis. So an instrument that is used in this is a variable that does not belong in this explanatory equation, meaning it doesn't explain why one type of access or a specific access is related to the outcome, but it is correlated with the endogenous explanatory variables, meaning it can predict what type of access you get, but not the association with the outcomes. So for this analysis, we used the operating physician's proclivity for AVF in the previous year. So of all the accesses this surgeon had placed, what proportion were fistula? So it's not this patient, it's the surgeon performing this. And just like an RCT, we have a consort flow diagram that shows where the patients drop out from the 239 that we started with. So within 6 months of dialysis initiation, 80% had a fistula created and 20% had a graft created. And this shows just the difference in the patients and patient characteristics. In blue, before the high density propensity score, and after in orange. So They did differ. Patients that had a fistula were generally younger and healthier, better SES and function, and fewer comorbidities and less healthcare utilization, but very good balance after we did the weighting. And 54% of those with a fistula died in a median follow-up of 2 years, and 59% of those with a graft. So this is after we applied the high dimensional propensity score, and this is the mortality hazard ratio. So, and this is time since placement. So in the first 6 months, those with a fistula had much lower risk of mortality. After about 6 months, it was very similar. And we couldn't think of a reason why placing a fistula would cause an immediate benefit of mortality. So we kind of assume this is residual confounding. These are the unmeasured confounders that we don't have in the claims because they should apply later too, and they don't. So we assumed it's unmeasured confounding. And after we apply the instrumental variable analysis, there's really no association at all. The hazard ratio for mortality is very consistent at about 0.98. So really no difference in mortality between the two groups. We looked at hospitalization, very similar. This is all-cause hospitalization. The first 6 months, very low hospitalization for those with a fistula, but when you adjust for the instrumental variable, there's no difference. Non-infectious access related, and that was true for all-cause cardiovascular related and infection related. For non-infectious access related, there actually was a fairly strong impact. Those with a fistula, even after the instrumental variable analysis, had a 24% lower risk of access related hospitalizations. In our subgroups, we found that all-cause hospitalization was lower in those without diabetes for a fistula, again, about 24% benefit. And a fistula was more strongly associated with lower access-related hospitalizations in those without diabetes and without peripheral vascular disease. So we concluded that if AV placement is not significantly associated with mortality, not significantly associated with hospitalization. We also not associated with the risk of sepsis, so I didn't show that, but it was significantly associated with a lower risk of access-related hospitalizations. And that represented a little less than 10% of all hospitalizations. But we also thought it may have benefits in those without diabetes or without peripheral vascular disease. Again, these are healthier patients, healthier vasculature. They probably have a longer life expectancy and a lower risk of maturation failure. So we certainly agree with the latest clinical practice recommendations that a patient-centered approach is needed to address these. There are still remaining questions, and I'll stop after this, but we need to know the impact on outcomes of interest to patients. It's shown that they're more interested in staying out of the hospital days, avoiding any procedures, both inpatient and outpatient, the quality of life. We need to look at other subgroups, especially younger patients and those with a combination of risk factors. So observational research, I think, has a critical role in informing clinical practice guidelines as randomized trials are not likely. To make them useful and informative, we need to creatively apply rigorous methods. The evidence review processes, a lot of times they sort of ignore observational studies in favor of randomized trials. And I think we need to look a little more closely at some of these. And putting this together, I also came to the realization that these clinical practice guidelines really are critical to focus the research efforts. We've not only informed those, we've responded to those when they have identified gaps in existing knowledge. So thank you very much. Happy to take any questions.
Great. Thank you so much, Brad, for a wonderful overview. And maybe I will start with the first question. So what advice would you give a physician seeing a patient in clinic who is heading down the road for dialysis? How, if you were a physician, how would you approach the discussions about vascular access?
Well, that's the question, isn't it?
Yes.
Well, hopefully we will have a much better answer to that soon. I am soon to resubmit a grant with one aim to design, test, and disseminate a patient decision aid to describe to the patient what their expected outcomes would be for going down one road or the other, and aid the provider-patient discussions when making that. There's really nothing like that right now. Most of the data on mortality, there's been studies that show that rank priorities for surgeons, nephrologists, and patients, and they don't match up. The surgeon wants a fistula to mature, no matter how long they have to use a catheter to get there. The patient wants to stay out of the hospital, and the nephrologist wants to keep them alive. So we have to talk about all those things at once, and it's very hard. So hopefully the data we're hoping to put together can address that.
Yeah, great.
I know that does not answer the question, but
it's not quite, but we're getting there. So hopefully
yes,
we'll get funded.
Yeah.
So a question from Carrie Gleason, in your observational data approach, did you do any subgroup analysis and look for differences based on race, sex, or other demographic factors?
We have some, and there appears to be less benefit for a fistula among women, especially older women. And we presume that that is also due to vessel size. There are differences by frailty. And again, we assume vessel size and vessel health. There are differences in maturation by race, where people of European descent appear to have better fistula maturation, which is not well understood. But that would have to play into any informative risk score or decision aid.
And then besides referring to a nephrologist, do you see other roles for primary care providers in this patient population?
Certainly, especially in one of the early slides where we talked about delaying or preventing progression of chronic kidney disease. By far the leading causes of kidney failure in the US are diabetes and hypertension. So our friends in cardiovascular medicine and endocrinology are going to play a huge role in that. And actually there's compelling data that the latest generation of anti-diabetic medications, the SGLT2 inhibitors, things like that, have a significant benefit in progression of kidney disease. So it's all those kind of things, before they even get to the nephrologist. But timely referral is also important.
Aji, you want to ask your question?
Sure, thank you, Lynn. Brad, what are your thoughts about kidney transplant recipients with a failing graft? Has that some level of accelerated aging or decelerated aging in terms of the biology of the blood vessels?
So I don't know if there's data on the specific pathological processes, but in general, even a failed transplant recipient is generally healthier than your standard dialysis patient. They were already selected to receive a transplant even if that fails, they are still selected as being healthier. Micah and I have done some analyses showing that failed transplant recipients, even though they know, they're under very direct care of transplant nephrologists, don't have much better preparation for restarting dialysis than the general population did in initiating dialysis the first time. Even though they see it coming, they're not prepared with mature fistula at the time it does happen.
Great. All right. All right. Well, I think those are the questions. So thank you so much for the overview. Look forward to when we have that patient decision tool. I think that, given all the complexities, I think that's going to be really helpful for our providers and patients. So thank you for your work in this field and for a wonderful presentation. And I hope everyone has a great weekend.
Thank you.
Thank you.